Now that you know everything about ground grass opacification, I will go faster, of course. And I will try to show you that there is different types of ground grass opacification. Sometimes the dysplastic and neoplastic conditions are related to nodular ground grass opacification, and sometimes they are more extended. The technical requirements are always the same. Just for nodular ground glass opacification, do high-resolution CT with a high-frequency algorithm. No contrast medium injection is required for the follow-up of these patients, and reduction of radiation dose is a good thing. Sometimes, if you see here the small nodule, and it's quite difficult to see, and it's why sometimes we miss nodules, and we discover the nodule 1 year after or 2 years after, and MIP reconstruction with thin slabs may help to disclose such nodules. You know that if we speak about dysplastic and neoplastic nodules, we go to screening. And when we screen patients that are at risk of lung cancer, we discover usually 3 types of nodules: small solid nodules, pure ground glass nodule, and partial ground glass nodules. This is a solid nodules, a mixed nodule, and a pure ground glass. And we have to know that the percentage of these nodules have been described recently again in this paper of the New England Journal of Medicine. Around 80% of the discovered nodules are solid. 20% are either mixed, 4%, or completely ground glass opacity nodules in around 16% of the cases. And this is a series not from Asia, but a series from North America, and we probably see the same things in Europe. So when you discover a nodule with a mixed or a pure ground glass opacity nodule, the first thing to do is to take your time. Don't hurry. Don't make the patient crazy with these nodules, because we know, because a lot of series have shown this, that if you repeat the CT scan 3 months after, between 30 to 16% of these nodules will vanish. They will disappear from the CT scan, the follow-up CT scan, because they are of inflammatory or infectious origin. It means that when you discover such a nodule, just ask the patient to come back 3 months later, no fibroscopy, no PET CT, no different exploration. And as in this patient, you will have the surprise that the nodule completely disappeared because it was a nodule related probably to an infection. And starting from now, I will only speak about the nodules that are persistent after 3 months control. There have been this new classification. Now, it's not really new because it's 3 years old, but it's still new for many people. And in this new classification that are due to the mixed knowledge of pathologists, surgeons, medical oncologists, radiologists, it was published with a multidisciplinary approach, and this new classification introduced new terms for classifying these lesions. And these new terms are here. There is pre-invasive lesions, such as the atypical adenomatous hyperplasia. There is the adenocarcinoma in situ, and there is also minimally invasive lesions. And this minimally invasive lesion is a minimally invasive adenocarcinoma, which is new. And there is then invasive adenocarcinoma. And you see that the term bronchiolo-alveolar carcinoma completely disappears from the language of pathologists and of radiologists. And we should not write a report with the term bronchiolo-alveolar carcinoma, because it's gone and it has been replaced by one of these terms. The story of adenocarcinoma could be this kind of story. We're not really sure, the pathologists are not really sure, but there is high things to say that it could be this. The first is AAH. Then you see why we look, when we scan this patient, we see ground glass opacification, because air has been replaced by these cells, but there is not a lot of cells, and it's still a lot of air between the alveoli, the alveolar walls. Then there is the AIS, here, in situ adenocarcinoma, then the minimally invasive carcinoma with the solid portion, and then the adenocarcinoma. And it may have this transformation of dysplastic condition to highly invasive condition. And the correlation of the pathology with the CT aspect showed that there is some correlation between the CT and pathology with pure ground glass opacity for AAH and AIS, and then Partsolid nodule in minimally invasive adenocarcinoma, then solid nodules. And the size of the nodule may increase as well as they may decrease, but the density or attenuation of the nodule increases. So first class is dysplastic nodules and the atypical Adenomatous hyperplasia. It's a pre-invasive lesion, and the pathologists describe this in 2 to 4% of patients without lung cancer. If they have a lobectomy in a patient without lung cancer, they find this in 2 to 4% of patients, 15 to 35% of patients if there is an adenocarcinoma. So this is related to adenocarcinoma. And if you look at the pathology example here, you really understand why we have a lot of problems to see these small nodules, because they have a very low attenuation on CT scan. And they are related to the proliferation of atypical type 2 pneumonocytes or Clara cells lining alveolar walls, but you see that there is a space between the cells and there is no cells within the alveoli. For us, when we see these conditions, they are pure, always pure ground glass opacity nodules that are spherical, with smooth limit, low density, without pleural retraction, without air bronchiogram or air bronchogram. They may be multiple within the lung, and the growth is really, really slow, and it's near 1,000 days. It means that to come from 4 to 5 millimeter, it will take nearly 3 years. So the growth is really, really slow. For the pathologists, they used to say that AAH are less than 5 millimeter in diameter. Sometimes they can reach 10 millimeter, but it's very rare that they give the diagnosis of AAH for a nodule, a pure ground glass nodule of 20 millimeter. Some people may have multiple nodules, and this is a patient with multiple ground glass opacity nodules in the apex. It's persistent nodules, and AAH has no influence on survival, even if they are multifocal. There is no indication for surgery, and there is no chemoprevention for this kind of lesion, and I will tell you later how to follow them. The second new category that have replaced bronchiolo-alveolar carcinoma is the adenocarcinoma in situ, which can be non-mucinous or can be mucinous. So this is a new term, and they are usually localized, small, less than 3 centimeters in diameter, nodules, with growth restricted to neoplastic cells along pre-existing alveolar structure, and you got here a nice example. But you see that the proliferation is larger and more important than in the previous lesion. And one thing is very important is that if you operate this patient, 100% of this patient will survive after 5 years after the surgery. This has direct implications for radiologists. The first is that it's a rare occurrence, 2 to 6% of all non-small cell lung cancers. The second is the diagnosis of adenocarcinoma in situ requires a complete resection, complete removal of the nodules, which means that transthoracic biopsy is inadequate to give this diagnosis, because the pathologist need to examine all nodules. There is many specificities for these tumors: epidemiology, natural history, clinical presentation, the pattern, and I will just show you the radiological patterns. This is one of these patients with a persistent nodules that increase slowly in size, and this is another AIS. 94% of AIS without alveolar collapse, this is pathological, is pure, as a pure appearance for us, but you may know that one patient may have an in situ tumor, but a mixed nodules, because if there is an alveolar collapse within the nodules, it will appear as a Partsolid nodules. So the correlation between adenocarcinoma in situ and pure ground glass is not always right, and we'll see that some of the patients have nodules that are mixed or even solid. This is another example, a pure nodule that was operated. And the second thing that is very important to know is that if you have a non-mucinous adenocarcinoma in situ, it's a pure GGO in the majority of cases, but if it's a mucinous, more aggressive tumor, it could be Partsolid or even solid. So it means that AIS may appear for radiologists as non-solid, Partsolid, or even solid nodules in some cases. This is another case, a patient with a nodule, a localized nodule. You see inside of the nodules some bronchiolectasis. The patient went on surgery, and it was a mucinous in situ adenocarcinoma. What about the volume doubling time? The volume doubling time of a solid nodule, solid adenocarcinoma, is around 150 days. The volume doubling time of AIS is 800 days. It means that it takes a long time to double the volume, which means that we have to follow this patient when the nodules are small for a long time. And we always have to refer to the first CT scanner and not to the last CT scanner that was acquired. An example, this is a patient that had a CT scan, a low-dose CT scan, because he was exposed to asbestos. There was a nodule here, but we missed the nodule. We didn't see it. And the patient came, it was in 2004, he came in 2011, and we found the same nodules, 17 millimeter in diameter, 12 millimeter in diameter. It means that the volume doubling time was 1,800 days, which means a very low growth. The patient was operated after this. What is the differential diagnosis? There is many of them. Persistent nodular GGO could be focal lung fibrosis, could be organizing pneumonia that persisted in time, could be all the other causes of adenocarcinoma in the lung, but also could also be metastasis, and there is rare care in the literature related to melanoma, renal cell carcinoma, or gastrointestinal carcinoma, but they could also be lymphoproliferative diseases. And usually speaking, if you have to take care of a patient with a cancer somewhere in the body and nodules, GGO nodule in the lung, the books and the literature says that usually the nodule in the lung is separated, has a pulmonary origin, and it's not related as a metastasis. Is there a role for FDG-PET? There is no role for this. Why? Because in pure GGO related to adenocarcinoma in situ, 67% of these nodules were negative for PET. It's the first reason. So you can say, okay, it's not a tumor because there is no high SUV. The second is when the patient had a nodule in the lung with a high SUV, the nuclear medicine can say, okay, it's a tumor, But in fact, many cases were related to infections. So when you find a nodule, you don't have to perform the FDG-PET. There is no indication in all the recommendation for following these patients. Let's move now to Partsolid nodules. You find some ground glass opacification, and then in the center or in the periphery of the nodule, you find some solid nodules. They could be related to AIS with alveolar collapse, and this is a nice case from the pathologist. But they can be also related to minimally invasive adenocarcinoma. And this is, again, a new term that we should use as radiologists. And you see here a patient with a tumor, a heterogeneous tumor, with some AAH, and then some in situ carcinoma, and then some areas of invasion. And usually the tumors are mixed and heterogeneous. And we may hope as radiologists to describe the same thing as the pathologist, which is the tumor is a majority of AIS, but invasion is present in less than 5 millimeters in diameter. But to be honest, because of the low resolution of our CT, with a 0.2 to 0.3 millimeter, it's not sufficient to detect slightly increase of GGO intensity, indicating minimally invasive histopathologically. It's why a lot of patients with pure GGO have, in fact, minimally invasive adenocarcinoma. So, minimally invasive adenocarcinoma are small nodules, pure lipidic growth, with less than 5 centimeter invasion on histology. There is non-mucinous MIA, and there is also mucinous MIA, but we have to say that there is a large overlap between imaging features of all these different kinds of nodules. This is a case. You see here a perfect mixed ground glass opacity nodules, solid portion in the center of the nodules, surrounded by ground glass opacification, or curious nodules with solid portion and some ground glass opacity. What about these nodules? How frequently are they malignant? And the LCAP study, published 10 years ago, showed that malignancy, these nodules are malignant in about 34% of cases, and usually, and in all series, shows the same results. Partsolid nodules are more often malignant than pure ground glass opacity nodules. I want to show you on this image that sometimes the nodules do not increase in size. 2005, you see the ground glass opacity nodules, and if you go 3 years after, the nodule has exactly the same size, but the attenuation of the nodule increased slightly, and the patient was operated, and it was an adenocarcinoma with a large area of AIS, but also acinury and papillary in the central part, so it was an invasive adenocarcinoma. The size didn't increase, but the attenuation increased. Is there a prognosis? What are the prognosis implication of CT pattern? There is some implication of what we see, because if we see a nodule with a large part of ground glass opacification, the prognosis is better than if the nodule has a small part of ground glass opacification. And then we move to the last part of this classification, lipidic predominant adenocarcinoma, and other adenocarcinomas. All these invasive adenocarcinoma are very frequent and much more frequent than the minimally invasive or in situ adenocarcinoma. They are often of complex mixture of histological subtypes. They're usually larger than the pre-invasive or minimally invasive tumors. They have a lower percentage of ground glass opacification than the two other kind of nodules, and the speculation is associated with lymph node metastasis and vascular invasion. There is two types. You see here nodules. The central part has a solid density, The peripheral part has some ground glass opacification. The patient was operated. It was a solid, a lipidic predominant adenocarcinoma, an invasive adenocarcinoma. This is another one. It's larger than the nodules I showed you before, and it was invasive. So we can dream of a very good correlation between CT and histology, but it's not so great, except for this Adenomatous hyperplasia, which appears always in ground glass opacification and small size, less than 10 millimeter in diameter. In situ adenocarcinoma may appear as ground glass opacification, but also mixed GGO and also solid if there is a collapse in the cells. Minimally invasive adenocarcinoma may appear as ground glass opacification, but also mixed GGO. Lipidic invasive, the same presentation, and even invasive adenocarcinoma may appear as pure GGO because our CT scans are not able to disclose, to show the images. And this was well presented in this paper of the AJR this week, or last month. And it's quite new, and it's not so great for us as radiologists because the correlation is not perfect. Now, what to do with these patients? The follow-up proposed by the Fleischner in 2005 is not adequate for this because we speak about ground glass opacification, and they proposed a follow-up for solid nodules. So the Fleischner proposed last year a new follow-up for these non-solid nodules, and I present this to you. If the nodules is less than 5 millimeter in diameter, there is no follow-up required. If the nodules is bigger than 5 millimeter and persistent, you should follow up at 3 months to confirm the persistence of the nodules, and then propose a follow-up for 3 years at least, sometimes 4 or 5 years. It depends the size, and another paper speak about the size. PET-CT has a limited value, is not recommended in such pure ground glass nodules. If it's a solitary Partsolid nodule, so more aggressive tumor, initial follow-up at 3 months is recommended before doing something. If it's persistent and if the solid component is less than 5 millimeter, this recommendation proposed to follow up this patient every year with a CT at least for 5 years. If the persistent and solid component is larger than 5 millimeter, they propose either to perform a biopsy or a surgical resection. And PET-CT is recommended for the nodules that are larger than 10 millimeter in diameter. And if you got multiple ground glass opacity nodules and they are pure, even if they are less than 5 millimeter, they propose to follow the patient at 2 years and 4 years to see if the nodule increase in size. And if the dominant nodules has a Partsolid or solid component, you do the same as it was unique. The paper I showed you before from the AJR this month is quite interesting because it tries to give you a level of size after which you can act for surgery. Because we know now that about 80% of persistent pure GGO are dysplastic or neoplastic. Pure GGO bigger than 10 millimeter tend to be minimally invasive adenocarcinoma, and pure GGO larger than 16.4 millimeter tend to be invasive adenocarcinoma. So in this paper, they propose to follow pure GGO less than 10 millimeter till they reach 15 millimeter, and for pure GGO larger than 15 millimeter, they ask the surgeon to operate the patient to take away the nodules. And they also introduce a limit of age because of the slow growth of this kind of nodules, and the limit age proposed in this paper is 70 years. Now we move to another type of adenocarcinoma, and this was called Mucinous BAC, bronchiolo-alveolar carcinoma. So it's a diffuse disease or more large disease. Patients may be symptomatic in about half of the cases with cough, bronchorrhea, chest pain. Usually it appears as a pneumonia or a persistent pneumonia more than 8 weeks after antibiotic administration. And I show you some cases. This is a patient with localized consolidation of the lung with some micronodules of ground grass opacification, and it was persistent for weeks and weeks despite the administration of antibiotics. Fibroscopy was negative, and we did a transthoracic core biopsy that showed that it was an invasive mucinous adenocarcinoma. So this type of adenocarcinoma may appear as crazy paving, pulmonary consolidation, centrilobular ground glass nodules, but more extended, with air bronchogram, angiogram, pleural effusion in few cases, or even enlarged lymph nodes. So it indicates that they are invasive tumors. Another case, this is a patient, you see this in June with pneumonia. In September, the pneumonia is still here. CT scan was performed in October. Usually there is a long time waiting for this kind of patient. They don't complain of a lot of signs. And you see clearly that there was a consolidation plus ground grass opacification, and the whole lobe was obstructed. The patient went to surgery. It was invasive mucinous adenocarcinoma, but 4 months after, you see that there was metastasis all over the lung because this tumor migrates through the bronchi from one lobe to another lobe. And finally, in some of these poor patients, they have ground grass opacification that are very dense in the bases and go up and up like a wave in the lung. You see them every 2 months for CT scan, and you see the ground grass opacification raising. And this is a patient I saw 2 weeks ago with an invasive mucinous adenocarcinoma with no effect of the chemotherapy. There is this tumoral or carcinomatous cause of diffuse ground grass opacification. I took this from the literature. This is a patient with non-Hodgkin lymphoma with diffuse ground grass opacification. So lymphoma may present as this, but it's quite rare. And this is more frequent. This is a patient with pulmonary lymphangitis, but you see that there is ground grass opacification, but also thickening of the interlobular septa. So to conclude, persistent GGO nodules are mainly due to dysplastic or neoplastic nodules. The new classification should be used by radiologists because we speak with other specialists that are using it now. Former localized bronchiolo-alveolar carcinoma are called now either in situ adenocarcinoma or minimally invasive adenocarcinoma. They have both an excellent prognosis after surgery. And for the follow-up, we should follow the Fleischner recommendation. And former mucinous bronchiolo-alveolar carcinoma, the diffuse form, should be called now invasive mucinous adenocarcinoma. It's a lipidic diffusion of the tumor. Usually it's bilateral, and there have been changes in treatment with the new tyrosine kinase inhibitor and other new treatment, but the prognosis remains very poor for this patient. Thank you very much.